Welcome to our August Senior Health Series on Care Coordination. Thank you so much for joining us today. Another beautiful day. Today is our last Senior Health Series event in the restaurant, so we so appreciate them for hosting us and closing their doors so that they can accommodate our session for today. Starting in October, we're going to be back in those conference rooms, so just a reminder, I'll remind you at the end also for the remainder of the Senior Health Series for this year. Joining us today, we have members from the University of Michigan Health Sparrow IT team. They are in the back. They are waving at you. They are here to help you if you have questions with signing up for your patient portal. So if you have already signed up for that and you're able to get your test results and get your messages from your doctor already, awesome. If you haven't done that yet and you're interested in learning more or you have questions about what it is or why it would be a benefit to you, please stop by, talk with them. They'll be available for a little bit afterwards as well. So if you haven't got a chance to speak with them yet, they're very nice. And the IT teams, like personally, is my favorite people because they answer the hard questions, the questions that make sometimes work challenging, and then I can get back to doing my job. So they're really valuable members of our UMH Sparrow community. Special thank you today. Some of you saw our friend Michelle from Bircham Hills. Bircham Hills is a generous supporter and sponsor for the Senior Health Series for this year. So we want to thank them for their support and their engagement. Joining me here this morning is Anna Melville, the Director of Population Health at Sparrow, and Deanna Bachman, one of the nurses who leads some of the efforts around the Sparrow Care Network. So thank you so much for being here. Please join me in giving these ladies a warm welcome.
Well, good almost afternoon. Thank you so much for having us. I really appreciate the opportunity to talk about what population health does here at U of M Health Sparrow and more so across the region. We did have the opportunity to talk to the Givens family before we came today. For those of you that know them, they sent us a few reminders of what we need to let you guys all know. So one, they said, bring your community resource guide. So if you did not, at the entry, there should be some hard copy resource guides and overviews to some of our team members, which I think could be helpful in what a lot of our programming is about. They said, talk about the importance of annual wellness visits. So Deanna is going to talk about the importance of annual wellness visits. And then Dr. Gibbons said, make sure everyone knows how important my chart is. And so that is why we have our lovely IT colleagues in the background helping you today kind of get that set up and started if you have any questions. So without further ado, what's going to happen this afternoon between Deanna and I is I'm going to start the presentation, talk about population as a whole, talk about the theory behind it, and then I'm going to turn over to Deanna, who has been with us since the beginning and really has seen these programs evolve, and she is going to dig into the importance of these programs for our senior population. So without further ado, let's talk a little bit about pop health. So I think if you ask 10 different people what population health is, you're going to get 10 different answers. It's a bit nebulous. A lot of times what they kind of anchor themselves on is what we've heard of as the triple aim or the quadruple aim or now the quintuple aim, which really is about, improved patient care, enhancing the health for a defined population, provider satisfaction, and then bringing down the larger healthcare costs without going too much into healthcare economics. What we are here to talk about really is the critical elements of population health management. Really, it's about having your accountable network of providers. That's our medical group. That's who we work with on the daily to implement these programs. We're going to be talking about the well-coordinated programs and that care coordination piece for our populations, the centralized infrastructure to get you the resources you need. Yes?
Can you speak a little louder?
Yes. All right. Is this okay? A little better?
Yeah.
I'll move over here. And then alignment with local market resources. So a lot of what we do is in support of community-based organizations, nonprofits, aligning with them to make sure that we're really creating that safety net for our patients in the community. This is a visual we've used since the beginning. I know it's a little hard to see. If we can get you the PowerPoint after, I'm more than happy to do it. But it talks about kind of the inner rings of what you're going to experience as a patient. Really from those community resources that we talked about being that outer ring, whether it's churches or support groups or what it might not be. And then you're really going to get into like your specialists and your health systems. And then really at the core of what we're going to talk about today is that medical home. That is your primary care practice. And you within the middle of it, which really brings it all together. So I talked a little bit about a patient-centered medical home, and this is a term we quite often use. This is about bringing the care to you and making sure you have the resources you need. This is about a team-based approach. So you're not only seeing your primary care physician anymore, you might be seeing APP, a nurse, a social worker, others within the practice that can help you with your care. Enhancing access, making sure you're actually able to get into your primary care practice. That's going to be big. Chronic disease management. We've heard a lot about chronic diseases and how we kind of need to bring back that high-risk population and take care of those chronic diseases. Preventative care, if we can help take care of an issue before it becomes a crisis, that is what we're all about. And then quality improvement. Again, a few more stats on the importance of kind of having that patient-centered medical home. When you're working with one of our practices, which all of our primary care practices are patient-centered medical homes, you're going to see a decrease in readmissions. You're going to see a decrease in ED visits. They are going to do everything they can for you in the practice so that you're not having to go downtown, wait in lines, see a specialist, etc. Anything that we can do in the primary care practice is really what we're here to take care of. You're going to see this visual throughout the presentation with Deanna. We are going to go through these 6 programs that really focus on care coordination. Again, kind of anchored on what population health is. We've been here with Sparrow since 2016. We've grown a lot over that time, from 2 FTEs to over 60 just in the mid-Michigan region. I think we work closely with the medical group and feel very strongly about that partnership as we advance towards value-based care. And then I think we see a bright future moving forward and how we're going to better provide services for the patients and really kind of connect. While we've been focused on what they call ambulatory or primary care, I think there's some opportunities with our inpatient side, with our skilled nursing facilities, with specialists, and we have to start connecting those pieces a little better. So with that, I'm going to hand it over to Deanna to talk about some of our programs.
Thank you. Well, good morning, afternoon. If you're a glass half full or glass half empty person, I'll call it afternoon. My name is Deanna. I am one of the managers over in population health. And as Anna said, I go back a little ways in the department. And so I really appreciate being able to come and talk with you. I think when a lot of us think about healthcare, we think about kind of those crises. We think about ending up in the hospital or that diagnosis that, we've kind of been dreading to hear. But we really like to say that we focus on the other, hopefully 364 days of the year when you're caring for yourself at home, when you're maintaining all of your functionality and your vibrance and sort of how we help you with that from both a chronic condition management, but also from a wellness perspective. So, care coordination, I think, is a term that we hear. I don't know if anybody can really define what that means. Again, I think it means something different to everyone. But, when we talk about care coordination, we're really looking at how complex healthcare has become. I don't think anybody could say that they've had it all figured out, right? Our healthcare system is more and more complicated. The conditions we're living with are more and more complicated. And so we really search to find ways where we can partner with the patient, partner with your physicians, and help sort of pull that all together so that you know how to kind of navigate your care and advocate for yourself. So one of the kind of flagship or foundational programs in population health is care management. So care management is done different ways in different health systems. We really believe that we have a strong model that works very well for patients in keeping your care centered in that medical home. So we have a team of 23, maybe as of this week, RNs who are experienced in all different areas of healthcare, but they are stationed right there in the primary care practice. So they are getting handoffs from physicians. They are getting requests from patients sometimes to see them. Maybe they have a medical assistant who is rooming a patient, and there is a need that the patient has identified that they need some help in managing their care. And so we provide that care management services both on kind of an episodic or kind of an intermittent basis, as well as helping patients with chronic conditions and working with them over a period of time. So care management is again, at all of our primary care locations here in the Health Sparrow entity. Some of the things that we will do for patients who are involved in care management might be working with them on medications, understanding how to best take your medications. What are they for? Is there a way that you can take them to optimize them? How can you manage side effects with your provider of those medicines, especially when there's something new or a very complex medication regimen that you're on? They're there to kind of give you that expert support with medications. Our care managers refer patients to medical services, social support services. Some of you may have heard terms like barriers to care or social determinants of health. And so our care managers are able to look at kind of the whole picture, not just the diagnosis or that medical condition, and say, how do we get you what you need so that you can be as healthy as you can be? They do proactive outreach. So sometimes we have patients who might be managing conditions like diabetes or heart failure. And so they're regularly checking in with patients to know, how are your symptoms going? Do you know when to call the doctor and request help? Can you tell when things are starting to go in a negative direction? So again, we can intervene, get you in to see your doctor, and be monitoring the changes in your treatment plan. One of the other big things that I think might be important to this group, we all know that as care has gotten more complicated, we have more than just your primary care, right? You might have 2, 3, 10 specialists who you're working with, and that becomes very difficult for the average patient to manage. How do I know how to get these people communicating to one another? We know we rely nowadays on a lot of electronic communication. How do I make sure that what I got from my cardiologist last week is transferred on to the surgeon or on to my primary care physician? And so care facilitators in that RN role can be really integral in knowing what is important to pass on. A lot of our work also is around health coaching and advocacy. So as a nurse, I think this is the most fun part of care management, is we really get to work with patients to say, what are your goals? What would you like to be able to do? You may have this condition, but how can I help you get to that next step? Or how can I help you care for yourself at home so you don't have to come and see us every day? Because who likes to go to the doctor?
Yay.
Yay. Oops, here we go. So another type of care management that we offer is called transitional care management. And so this is a very kind of specific scope that care managers, for us here at Sparrow, this again is another team of RNs that really help support patients when they've had a discharge from an inpatient setting. So this might be, again, from a hospital stay, or it might be from a subacute rehab or long-term care facility. What we know is that those transitions of care can be very, very risky for patients. There's a lot of things that can fall through the cracks. There's a lot of information that needs to be transmitted and built into your care plan. So we provide transitional care management services. This ensures that an RN is reaching out to the patient or the family member within 2 days of leaving one of those inpatient settings. The priority there, again, is to sort of fill that gap, create that bridge between when you left the hospital and when you can get back in to see your primary care and or your specialty providers. So again, do you know how to take these new medicines properly? Do you know what medicines you were supposed to stop that this one now replaces? If you're to have other services, home care, durable medical equipment, they're going to help to make sure that those things have arrived to you and that you have what you need as intended when you left the hospital. Again, the coordination of care, ensuring that you have an advocate to get you into those appointments, to make sure that you're not waiting 4 months after you left the hospital to have your follow-up, and really be able to work internally to make sure that you get that care, to make sure that you don't have to go back anytime soon. Sorry, this button's fighting me. So just to give you kind of a picture, I don't know if any of you have had the occasion to hear from one of these nurses. Here are some faces behind the names. But again, we have a centralized group of nurses. Their skill set is truly how to help patients transition out of the hospital and create that safety net. Wonderful group of nurses. I hope you get to talk to them. I hope you don't have to talk to them, but if you ever do, just want to reassure you that they're there and they're actively working on your behalf. Even though they're centralized, they are reaching out to your physicians. They're coordinating the care with you and your care team. So behavioral health is, I think, more important than it has ever been before in our culture and in our community. In 2020, population health, along with the rest of the health system, realized, we really need to get behavioral health care into the hands of our patients. And so we have the population health department has created a program where we have, again, like the care facilitators, we've embedded social workers into the primary care practices. So they are able to kind of take that other side of us when we look at healthcare and kind of combine that medical and behavioral health team together. So covering about 22 practices, we're continuing to grow. So we have a couple of practices who don't yet have this, but we anticipate that will happen very soon. We have gotten a ton of great feedback. Having a patient who's having a behavioral health need who doesn't kind of get turfed out the door with a piece of paper to say, here's 30 numbers you can call, being able to get that care started and have an assessment or having some sort of crisis intervention has really been very, very beneficial. We hear from our patients and our providers as well. Again, one of the things that we're always looking to do is avoid those unnecessary hospitalizations and ED visits. So again, if we can intervene at that point of care when you're coming to see your provider and things just aren't going well, being able to institute that behavioral health care earlier. So these social workers provide short-term therapy, usually somewhere 6, 7, 8 visits. And they're really able to kind of cover the full gamut of behavioral health therapy services. So things like depression, anxiety, grief and loss, relationship issues, coping with chronic conditions. They're able to see patients for those. They are, again, able to work with your physician. So this is, again, I think something that's very important. If you maybe have a physician who's managing your medications for some of these conditions and you're seeing the social worker, they can work together to make sure that you are getting to recovery sooner and that you're tolerating the medications and that you're getting the benefit that you would expect. Again, they're able to triage some behavioral health services and crisis care. One of the things that they really can help with is making sure that the patient gets to the right level of care. So if a patient needs to be in the emergency room, we want them to be in the emergency room. But when there's a better source of care that's more outpatient or supports the patient in a way that is more acceptable to them, we want to be able to get them into those services. And these social workers can help with that advocacy. Annual wellness visits. So this is my favorite. This is a program that I work pretty closely with. So annual wellness visits, while some people might not see this necessarily as care coordination, this is really a pivotal part of your coordinated care in your primary care home. So wellness visits are a visit that is covered by Medicare. All Medicare plans, whether you're on traditional or Advantage plans, you have a benefit of having this annual wellness visit. And this is really a set apart time for you to meet with a healthcare provider. This might be a physician, a nurse practitioner, or an RN who is able to create that personalized wellness and preventative care plan. I think most of us can say, I apologize to any doctors in the room, this is not their fault. When you get to the doctor, you have probably a list of things that you want to talk about or things that they have to talk with you about. And we don't always take that time out for wellness and prevention. And I think we all know that this is important, but sometimes it's hard to make time for that. And so really that's what the annual wellness visit is all about. These are covered. These are one of the few things that we get in the world that are free. These are truly free visits. They are covered by Medicare in their entirety. There really is a value, I think, that Medicare sees of having patients have these visits. So again, we're looking to be able to prevent. We're looking to see early detection of chronic diseases. We're looking to make sure that you have all of those preventative services, screenings for different types of conditions, cancers, making sure that your nutrition, your physical activity are optimized to keep you well and again, keep you functional and ward off those chronic diseases. So an annual wellness visit, there's a lot on this slide. Again, I know it's probably hard to see, but just wanted to give kind of a picture of how comprehensive the annual wellness visit is. Really, the crux of this is doing a very broad risk assessment. So we are asking questions. It might feel like a little bit of an interrogation, I think sometimes, but we're asking things about your medical history, your family history. We're updating all of those specialists that you're now seeing that are really important for your PCP to know that you're seeing. We're giving personalized health advice. So we're talking very specifically about those self-care activities that you're doing. What are we doing to prevent another fall if you've had a fall already this year? What are we doing to make sure that medical equipment that you're fighting with the insurance company every month to get and you're not using now because it's such a hassle? So able to kind of navigate through some of those things, again, to keep you well. We're going to talk with you about advanced care planning. If anyone is familiar with that term, that's again that conversation and those advocates that we set up to be able to make decisions for us if at some time we're not able to make them for ourselves. So during the annual wellness visit is a great time to talk about that and understand how you can establish an advocate and have those conversations with your healthcare team. Again, monitoring things, as far as weight and blood pressure and other markers of health, doing some cognitive screening. Everybody loves this. We check to see how your memory is. I know that's the best part of the annual wellness visit. I'd probably fail if I had to do it. And then again, just being able to coordinate those additional resources. So a very comprehensive look at screening and getting ahead of things that you can probably all agree you don't always have time to talk about when you have that 15-minute office visit with your doctor. And at that, I will toss it back over to Anna to talk about probably some of the really cool and newer things.
So Deanna might like annual wellness visits. These last two projects I adore. They kind of lean more towards the community health realm of population health and giving back to the community. So we have a navigation hub also established in 2020. This is for community health workers, resource coordinators, also with us centrally, who receive referral for SUH-related needs. So when you go to your primary care practice, you may see that you're screened for financial insecurity, food insecurity, transportation, whatever it might be. And if you were to screen positive on any of those questions, there is a referral that can be put in to our community health workers to reach out and provide personalized support. This is the providers can enter that referral. This is the front desk can enter those referrals. If anyone needs that extra level of support from the community, the referral can be made to the navigation hub. I'm not going to go through the details of the social drivers of health or the impact to the healthcare system. I think we all know if you're struggling to pay the bills monthly, you may not be picking up your medication, or you may put off that annual wellness visit or that specialty visit. And I think that compounds over time. What I will say with the implementation of the navigation hub, we can now feel comfortable, providers can feel comfortable asking those questions and knowing they now have an answer or support in that navigation hub or those resource coordinators. When we first rolled this out, I remember a PCP saying, I was nervous to ask those questions because I didn't know where to send my patients. And now they have that support. And so these ladies, I think we get about 3,500 referrals a year, are really working miracles with our community-based organizations and partners. The last thing that we're going to talk about here from a programming standpoint is producing change. This is the last one that we have rolled out. We've done a lot of work with our IT partners, with community-based organizations. This was an MD-HHS grant to the Michigan Health Endowment Fund that was really about connecting health systems with community-based organizations. I think we've all wanted to do that work, and we didn't know how. And this has helped connecting from an IT perspective, but also from resources. So we have a community dietitian, Caitlin, who is embedded at LMTS, which is on the south side of Lansing. So again, this is very much a partner between the Food Bank Council of Michigan, who has led us through this as we create this food pharmacy, the Greater Lansing Food Bank of Michigan, who has been helping us with the food ordering and food procurement, making sure we've got healthy meals available. And then the Food Pantry LMTS has been a wonderful partner and giving us a space in their location to do the nutrition educational consultation and then providing food, healthy food, based on the patient needs. The big thing here is this is connected to our chronic care management program. So what happens is if you do have a chronic disease and you flag for food insecurity, then a referral is made to Caitlin. And Caitlin's the one that ushers you through this food pharmacy program. I think the most important part of this, and you can see kind of the referrals month over month, is that when we hand you a bag of food every 2 weeks when you meet with Caitlin, it's not for your individual needs. We're feeding the entire family. That's part of the assessment. So you're starting the healthy eating early with the larger family, and the education is really based on that unit instead of just the patient. So we started this in 2024. This should say for June 2025. And you can see the household served, the people served, and then a kind of grouping of ages. I think April was our biggest, serving over 162 patients. In June, we had 121, and we have had 32 patients graduate from this program. It is early. This is a pilot, as we like to do. But what we're seeing is A1C is going down, blood pressure is going down, weight going down. We're actually seeing the results, and I think we set up this program in a way that's going to be meaningful for us to expand going forward. And while I think we have this right now for our Lansing area residents and primary care practices, I would really like to see this push to our rural health clinics and the communities out there. I think this could be very impactful. I had a plethora of patient stories to pick from. Again, I know there's a lot on this screen, but I did want to share some because I think this is really what healthcare is all about and giving back to the community. So a patient started the program in September 2024 with an A1C of 14 and weighed 247 pounds. The patient was not paying attention to the carbohydrate intake and had very little energy. The patient's most recent A1C did decrease to 13, and the weight went down to 228 pounds. With the help of the dietitian, the patient started going for short walks after meals to help stabilize blood sugar levels and has been paying more attention to the amount and space of carbohydrates in her diet. This patient takes pictures of her meal to help her remember to build her meals to look like the diabetes plate method. The patient reported to the dietitian that this program gives me hope. The second story. The patient reported that the program was such a blessing and shared that because of the food she received from this program, she was able to stretch her food budget to purchase fresh oranges, lemons, bananas, spring mix, cucumbers, and cherry tomatoes to have more fruit and vegetables on hand. The patient left the following comment. I'm really impressed with the program and praying that it expands because we really, really need it. So many people have spent so many years in poverty eating crappy food. So her words, not mine, but I think this is a very impactful program, and I'm excited to see where this one goes. So key takeaways for the larger presentation today between Deanna and I. Care coordination is a partnership between the patient, their support system, and the healthcare team. Integration of care is key to not only improving individual health, but also the health and wellness of the community around us. That's what population health is all about. U of M Health is committed to partnering with patients in their care to improve wellness, manage chronic diseases, and foster responsible stewardship of healthcare resources. If you are seeking a more collaborative care model, please talk to your primary care provider or visit uofmhealthsparrow.org. And then as a reminder, we got to give another shout out to our IT team members and the importance of MyChart, so you're getting up-to-date labs, visits, and everything scheduled through the app. So with that, I think we are open to questions. Thank you. Go for it.
You have a primary care physician that's outside of the U of M Sparrow circle. How do they get into it?
That is a good question. So you're looking to maybe join a primary care practice within U of M Health Sparrow?
Okay, and how does that happen?
That is a good question. I'm trying to think of the best way to get into a primary care practice.
This has been, I think, across not just our community. This is how do you get in, and how do you get in a timely manner. So one of the best resources is I'm going to maybe not know the website, but I can look it up and follow up with you. But maybe Melissa will get that. So we do have a website that lists all of our primary care practices, their locations, their hours, and they are keeping that very up to date to identify practices that are accepting new patients. So we do have very few practices at this point that are closed to new patients. I think the biggest thing to remember is to make sure if you are looking to kind of navigate to a Sparrow practice, even though they might be accepting new patients, it might be a couple of months before you can get in, work with your current provider, make sure that you have medication refills and things covered. But that website is the best place to look for kind of real-time information of where you can go in a place that's convenient to your home.
And go ahead.
Right, are you, for lack of a better term, are you guys going out and proselytizing to the medical community outside of U of M Sparrow? Are you trying to reach out to them?
No, not necessarily. I think again, from a Sparrow standpoint, we want to serve the community, and so there are people that interact with Sparrow. Maybe you have a McLaren or a Henry Ford primary care physician, but maybe you enter the Sparrow realm with a specialist you see, or maybe that's a hospital that you might visit. And so, we really want to be available to patients at any point of entry that they kind of touch the Sparrow system. We have wonderful physicians in the community that are affiliated with McLaren, Henry Ford. So we want you to continue to get your great care there. But if for some reason a Sparrow office is what you're looking for, of course, we'd love to have you. Did that answer your question?
Not really, but that's okay.
Okay.
We can get you direct contact information if you would like to, or figure out.
One of the biggest problems
Yeah.
that I see, A doesn't talk to B,
Mm-hmm.
and A and B don't talk to the patient.
Mm.
And so the patient's just sitting there like, well, where do I go now? I don't know what to do.
Yeah.
Yeah.
I just been diagnosed with my 5th chronic condition,
Sorry.
and the doctor's working with me. But again, the ball is getting bigger.
Yeah.
Mm-hmm.
Yeah. So the question I think maybe is how, when you do have people on your care team who are within different systems, how do we keep connected? So again, I think, from my perspective, that really is the foundational question of the medical home. And so when you look at it, and it doesn't matter if you're talking to an insurance company, if you're talking to a patient, the idea of the medical home is really where your care starts, that primary care physician, the way that we try to live, what we try to live by is that's your hub. We sometimes say that's your quarterback. And so, going back to that primary care home, we have a lot of ways. Again, I think the IT people could probably answer this better than I can. We are every week finding new ways to integrate how we have what we call health information exchange. How can we go through different systems that'll say, my patient had care at a hospital down in Florida when they were down south, or they were visiting a family member in Chicago. How can we get that information back into your record here? So I think there's some IT things that absolutely are a part, but that's also a place where, again, as your care gets more complicated, I think that's one of the most important roles of a care manager. And say, how do I get the information? How do we coordinate what's going on? It might not be forever. You might get to a point where you now have figured out who's who does what for me, but having a care manager can sometimes help you just understand, how do these things all fit together, and where do I go when I have this type of problem? Yeah.
You talk about the integration and not computerized talking with each other. My wife had to have a MRI. They tell her she's got a pacemaker, so she can't have it done here. She has to drive to Ann Arbor. When Ann Arbor says, okay, bring all your information down. Well, all that information is on the Sparrow portal. Now, it just seems if it's U of M and Sparrow, somehow they ought to talk. But what they're saying is that no, when we come back here can't talk with them. We have to get a CD of the MRI and an analysis and bring it up so that they can see it. I'm just a little confusing. If it's U of M Sparrow, are they really not talking to each other? And why can't they access the Sparrow portal so we're not having to do all this extra?
I think you guys are hitting on really good topics. First, access to care, primary care coordination, and then the integration with IT. And I'm looking at my IT colleagues as they are living this right now with 3 different instances of Epic, which is our EMR, or electronic medical record. And I know they're working on it, but it is going to take a few more years. And that is the seamless care coordination that we really want across Michigan from Ann Arbor to Sparrow to West, and to be connected, it's just going to take us a little bit longer. Yes.
Is my chart the same thing as my Sparrow?
Yes. Thank you. We call it.
Question.
Woo. Yes. My Sparrow and my chart are the same thing. So I appreciate that call out. Also, if we're using acronyms that you want us to, walk through, let us know. But that is a good call out, and I appreciate that. Yes.
2 quick questions. Are specific eligibility criteria for transition care management? Is there like a checklist that determines it, or is it that somebody thinks to ask?
It's a good question. So each health system does it a little differently. Within, I see the chuckle, within population health, we are making all of the calls. I think there's some exclusions for maybe a planned HIP or a low risk situation. Some of our OB patients that are going to be following up within days with their own practice are not the highest risk, but we do follow up with anyone discharged from Sparrow, Maine. You should be getting a call from our team.
The other question is on the behavioral health integration.
Yeah.
Is that adults only, or do you also do that service for children and adolescents?
We are training all of our social workers on the pediatric component of it. A majority of our patients so far have been adult, but there are definitely pediatric patients involved. I know Portland has a large pediatric population that is served by one of our social workers, but that program continues to evolve and anyone is eligible right now. The beautiful thing about behavioral health is they will let you know what their services are, what they're available for. You get to decide if you want to work with them. If you don't, they are going to help you refer out to the community and put you in good hands with a community member. So it's a one-stop shop for help. Yes?
What was the website that you referred to?
The one I referred to is, I'm going to point to Melissa here. It's going to keep me honest and make sure I got the up-to-date address.
I got distracted. So we talked about 2 websites. The one website for if you are looking for a primary care physician in our system, you go to the University of Michigan Health Sparrow website. On the primary care page, there's a beautiful list of all of our clinics, and the clinics that are accepting new patients have a big green check mark on it, so it's very clear to see who's available for you. I don't know, I got distracted. So if you were also talking about my Sparrow.
Was that helpful for the website you were looking for?
Actually, I couldn't hear.
Here you go, Melissa. I'm going to hand off. So we're so lucky to have our IT colleagues.
Yeah. So I know there was a question about new patients and getting a new patient appointment in the system. So
It's better.
if you're looking for a provider in our system, if you go to the University of Michigan Health Sparrow website, there's a primary care page. And right on that page, there's a list of all of our primary care clinics. And those clinics that are currently accepting new patients actually have a nice big green check mark next to them and it says accepting new patients. So you can find one that's close to your home or in a convenient location that is accepting new patients at this time. Yeah.
Most of our doctors are at MSU docs. Is that coordinated with what you're talking about, Sparrow?
So our population health services are really at Sparrow. That doesn't mean that we don't work with MSU specialties or that care management component that's going to work across the different health systems. But what we've established and who we are employed by is U of M Health Sparrow.
Okay, because we do have portals with them.
I do believe that at least the majority of the MSU health team, primary care, internal medicine offices do have care management. We interact, again, kind of care manager to care manager. So I definitely encourage you to check. They probably have some similar services there. Yeah.
But then we do have some docs like the surgeons and stuff.
Mm-hmm. Yep.
That are others. So going to all these different portals.
It makes for a lot of trips. Yep,
Yeah.
I agree.
Okay.
That's good. That's a pain point. I appreciate that.
So this is what the website looks like. I will talk with our marketing team. I don't know if there's an easy link to remember because it's quite lengthy. But you can see the green check mark above the at the practices that are accepting new patients, and it looks like it's most of them. But this is the primary care practices, and if you just go, I searched because I think the search is the fastest way for me to get where I want to go in most situations. So I just searched primary care, and this was the first website that came up for that question. Were there other questions for our presenters?
Is there any plan to reestablish geriatric primary practice?
It's a good question. I think we'd have to work with our medical group colleagues. I know that was a gem of a practice, and there's a lot of people who really enjoyed the services offered there. I think that's still being discussed. I know there's a few different clinics that are in talks, but I'm not sure specifically on the senior health clinic itself. Yes, a few more questions.
And if so, is there an extra charge for that?
It's a good question. So I think it was, is the care manager there sitting with your doctor, and is there an extra charge for that? So they do usually have their own independent office within the primary care clinic. There's a lot of warm handoffs that happen within the practice. Not usually are you with both the PCP and the care manager, but you could be. It's more likely that you'll be seeing your primary care physician for something. They will recognize an opportunity, hand off to the RN care facilitator or the social worker, depending on the need, and then those individuals will either see you right then and there, or they'll be reaching out to you to schedule. It depends a lot on insurance and payer related to copays. I can't speak to everything, but it just depends on the services provided and the insurance coverage for the details of that.
Let's give a warm thank you to our speakers today. October 1st is our next Senior Health Series event. The topic is on cancer awareness and treatment. One of our esteemed colleagues, Dr. Gordon Sirkalovich, is going to be presenting at that. He's with the Herbert Herman Cancer Center. He's a phenomenal speaker. If you've been to lunch with the doctor ages ago, you've probably heard him speak, but he's phenomenal and extremely well-versed in cancer care. And so I hope that you'll come in October. We'll be in the other rooms. If you have questions today, we'll have people here afterwards to be able to answer them. But thank you so much for joining us today. I hope you have a good rest of your day.
Thank you.